Hi, everybody. Thank you so much for joining us. I'm State Senator Jason Lewis, and tonight we'll be discussing the safety, efficacy, and availability of the 3 approved COVID-19 vaccines in the United States. I want to thank both Tom Dalton and Emily Grana from my office for organizing tonight's event. And I also want to thank all of our local cable access stations who are broadcasting this event in addition to it being live streamed on Facebook. It's hard to believe that 1 year almost exactly 1 year has passed since the pandemic totally upended our lives and caused so much suffering. But there is finally a light at the end of the tunnel, with more people getting vaccinated every day and the expected signing later this week of the American Rescue Plan by President Biden. We should acknowledge that the vaccine rollout in Massachusetts has been very rocky, with a poorly designed sign-up process, confusing and often changing guidelines and prioritization, disagreement over how and where to allocate limited vaccine doses, and lack of clear communication. The state legislature held an oversight hearing recently to hold the Baker administration accountable for its performance during the vaccine rollout, and importantly, to ensure that improvements to this process are being made as quickly as possible. Additional legislative oversight hearings are planned in the coming weeks. Despite this rocky rollout, more than 2 million vaccine doses have been administered so far here in Massachusetts. About 760,000 people are already fully vaccinated. So that means they've received both doses of either the Moderna or the Pfizer vaccine, or one shot of the J&J vaccine. The spread of the COVID-19 virus has diminished significantly in recent weeks, and the state's positivity rate has fallen to 1.7%. These, of course, are all very positive developments, but we have a ways to go before the pandemic is behind us, and we certainly need to keep up our guard, and we also likely have several years of recovery efforts ahead of us. I'm very pleased that Governor Baker finally heeded calls from President Biden, legislators like myself and Senate President and the Speaker of the House, teachers, parents, and others to begin the process of vaccinating teachers and other school staff and early educators. This will greatly facilitate the reopening of more schools in Massachusetts and enable more students, but especially our youngest learners, to be fully back in school in person in the near future. Earlier today, Governor Baker, again in response to pressure from legislators and the public, announced that starting Friday this week, there will now be a pre-registration process for vaccine signups. This is very good news and should make the process of getting vaccinated much easier and less stressful for all of us going forward. We know that folks still have many questions about the COVID vaccines. So tonight we are very fortunate to be joined by Dr. Luann Bruno-Murtha. In fact, she's back by popular demand after joining us twice before to discuss the pandemic and COVID vaccines. So I'm sure she's familiar to many of you already. Dr. Bruno-Murtha, to remind you, is an internal medicine and infectious disease physician and an assistant professor of medicine at Harvard Medical School. She serves as the Division Chief of Infectious Diseases at Cambridge Health Alliance. Dr. Bruno-Murtha will be making a presentation, and then we look forward to answering all of your questions. So please go ahead and start putting your questions in the Facebook chat, and then Tom will display them across the screen so we can all see them, and we will do our best to answer them all this evening. Dr. Bruno-Murtha, welcome. And again, thank you so much. We're delighted to have you with us, helping us understand and answer all these questions about the COVID vaccines.
Thank you, Senator Lewis. I'm very pleased to be back and share some information. I wanted to share some information about the new vaccine, the latest to receive the emergency use authorization from the FDA, the Janssen vaccine, otherwise known as the J&J vaccine. So I'm going to share some information with you on that. But we can open the questions up to any of the vaccines. I have a presentation that I'm going to share on my screen, which is specific for the newest vaccine, the Johnson & Johnson, or the Janssen, which I understand is the correct nomenclature. Are you seeing my screen yet? Oh, no, not yet, probably. Okay, you'll see it now.
Not yet, but there we go. Now we see it.
Okay, great.
Yep.
And here is the presentation. You should see my title slide. So what I intend to do is to give an overview of the Janssen single dose COVID-19 vaccine, and you'll see it abbreviated AD26. That's short for Adenovirus 26. COVID-2 for the disease. So let's get started with a few comments. This should take no more than 20 minutes, so we have ample time for questions. So the third vaccine that became available in the US was based on a study, a very large study, just like the other two vaccines, over 44,000 participants, half of which received the vaccine and half of which received a saline placebo. Now, this vaccine trial was somewhat different than the mRNA vaccines, and I'm referring to the Pfizer or the Moderna vaccine, because it was done at a time where disease was surging in all the locations where the study was performed. The study was performed in the US, in South Africa, and in South America, and there was a lot of disease at the time. And what we've learned from this clinical trial is that it offers substantial protection, especially against severe disease, against hospitalization and death. And it provided us insights into efficacy in areas of the world where we know there are variants of concern circulating, like in South Africa. We know from this large clinical trial that it was well tolerated and safe. And one of the big advantages of this vaccine is that it's one and done. You get one dose, and 2 weeks after that dose, you are immune to serious infection and hospitalization. And the other advantage this vaccine has is that it does not require the very cold temperatures that the mRNA vaccine requires. So it could be stored in a refrigerator for up to 3 months and several, even longer, in a freezer. So it has some real advantages. So let's dive into some of the key findings of this large clinical trial. So it demonstrated, and I want to point out, you're going to hear different numbers in the media. You're going to hear comparisons to the Pfizer and Moderna vaccine, but it really depends on what efficacy they're describing. This study described efficacy looking at 2 different time periods, at day 14 after the vaccine and day 28 after the vaccine, whereas the mRNA vaccine just looked at day 14. So you have to be careful when you're hearing about direct comparisons. It's not fair to have direct comparisons because of the way these trials were conducted. They all were conducted in different geographic areas at different time frames and using slightly different definitions. So I just want to caution you about that. So be careful when I give you a percentage, because it depends on what particular time frame I'm describing. So if we look at 28 days after the vaccine, the clinical trial demonstrated 85% vaccine efficacy overall in all geographic areas combined, including the United States. If we look at 28 days in South Africa, where the variant of concern is circulating, that's often referred to as the B1351 strain, we know that it's prevalent there. More than 95% of the cases at the time of the study was due to that strain. It had 85% efficacy. And we don't have good data about the efficacy of the other mRNA vaccines. because they were not studied at a time we were dealing with these variants of concern. It offered complete protection against hospitalization at day 28. And this is really the most remarkable thing, there were no COVID-related deaths in this study after day 28, and there were 5 in the placebo group. There was a 72% vaccine efficacy against all disease, moderate, severe, and critical disease in the United States. And that included more than 19,000 patients. And a 66% vaccine efficacy against moderate, severe, and critical disease across all countries. And that's at a 2-week time frame. So 14 days after the dose, it had an overall 66% vaccine efficacy. And when you looked at subpopulations by age, by comorbidities, by sex, race, or ethnicity, there were no differences of concern detected in this clinical trial. This is a map of where the study was conducted and looking at the different strains that were circulating. So the study was conducted in the US, where the vaccine efficacy against severe and critical disease, so the type of the disease, severity, which would culminate in hospitalization or critical care or respiratory failure, it had vaccine efficacy in this country of 86%. In Brazil, where the variant of concern was circulating, and this is actually the P2 variant. It's not the same variant that we're hearing about along the northern part of Brazil, in Manaus. That's the P1 variant. So where this study was conducted, 69% of the strains circulating at the time were the P2 variant, and it was 88% effective against severe or critical illness, so the type of illness that would culminate in hospitalization. And lastly, in South Africa, where we know there's a serious variant of concern, it had 82% efficacy. So a little bit less, but still very robust efficacy in the presence of a serious vaccine. So regardless of where the trial was conducted, it was very effective. Well, this is a platform that you may not be familiar with. It differs from the messenger RNA vaccine platform because it uses an adenovirus. Adenovirus is an uncommon cause of a common cold and pink eye. And the adenovirus 26 is a particular strain that is not that of a common cause of these diseases. So what they have done is they've used this adenovirus, which is no longer able to replicate in our body. It is replication incompetent. So it's safe to give this vaccine to immunocompromised patients because the vaccine cannot replicate and cause disease in our bodies. It's only used, the adenovirus is used as a vector or as a transporter or as a shuttle, so to speak, to take into our muscle cells where we're injected with this vaccine, to take in the instructions of the spike protein so that our body, very similar to what we saw with the prior vaccines, where they're using a fat particle or a lipid to take in the genetic material so that our muscle cells can transcribe that genetic material to produce spike protein so that our normal host defenses can start to produce an immune response to that spike protein. So the difference here is that we're using an adenovirus instead of a lipid particle to bring the instructions into our cells so that our cells can then take over the process of producing the spike protein and then our body producing the immune response. So this technology, the adenovirus technology, is not new. We've been, scientists been studying this and using it for other vaccines. It's been used for HIV vaccine research. It's been used for Ebola virus research, and it's been administered in many different types of patient populations, including in older adults, in pregnant women, in breastfeeding women. So it's had a lot of experience. So it's not a new platform. And adenovirus vaccines have been administered to more than 193,000 patients. And so I just want to mention that although you hear the word adenovirus, it makes you fearful that can it make me sick? It cannot make you sick from the virus. The virus is not able to replicate in your body. And this virus does not include any animal products, byproducts, or components. And so it consists of the genetic material for the spike protein, the adenovirus, which acts as the shuttle, and some buffers. There are no adjuvants in this vaccine. Protein vaccines that we get for a number of other diseases to prevent illness do have adjuvants to boost the immune system. This does not have an adjuvant. It does not have antibiotics in it, and it has no preservatives in it. So this is a nice cartoon to really explain how this works. So you get a vaccine injected into your deltoid muscle. And again, the adenovirus depicted here in blue is just a shuttle. It's bringing a piece of genetic material into your cell so that your cell can produce the spike protein, which is then expressed on the surface of your cells and is recognized by a cell in your body called an antigen-presenting cell. And that antigen-presenting cell takes the spike protein and carries it to a lymph node where it activates your B cells. Those are the cells that actually produce antibodies. Those are the proteins that circulate in our body so that if we get infected with the SARS-CoV-2 virus, the antibodies attack the virus and neutralize it. The antigen-presenting cell also activates another arm of the immune system, the T cell immunity, that is very important and has been demonstrated to be important for long-term immunity. And so this virus, similar to the mRNA viruses, activate both arms of the immune system. The humoral immunity, that's the part that produces the antibodies demonstrated here, and the cellular immunity, that's the T cells that work in conjunction with the B cells and also provide the ability for more long-term memory. So this study does differ than the other studies that you have become familiar with over the course of the past year, because when they looked at efficacy, they looked at two different time frames. They looked at 14 days and 28 days. And so when you hear about the differences in vaccine efficacy, it's important to recognize that there may be different time frames that you're hearing about. I do want to demonstrate one aspect of this clinical trial that was superior to the other clinical trials, and that is the diversity of study participants. They did an excellent job increasing the diversity of the study participants. Black or African American participants accounted for nearly 20% of all study participants, and Hispanic and Latino participants accounted for 45% of participants. And if you were to compare and look across these different columns, looking at those patients that received the vaccine versus those patients that received the salt or saline placebo, it was very well distributed across the board. So it was a very well conducted study. We want to see that both populations are very similar in terms of race and ethnicity and age and so forth. So let's get to the endpoints. The top panel that you're seeing here demonstrates the global results, so all areas of the world where this study was conducted. And we're looking at 14-day efficacy and 28-day efficacy. So globally, the efficacy was about 66% at both 14 days and about at 66 days. If we look at efficacy, let's see if I could hide this. Yeah, if we look at efficacy just in the United States, at 14 days, it was 44%, and at 28 days, it was 72%. So there's improved efficacy in the US, probably contributed to the fact that we might have better access to health care. We might be performing our physical distancing and our masking better, and probably because we don't have some of those more serious variants of concern circulating like they did in South Africa. So very good efficacy. And this is looking at all disease, so moderate, it's all disease categories combined. If we look at just severe and critical disease globally, and quite frankly, this is what we want to prevent. We want to prevent patients from having to go to the hospital or having to go to the critical care unit. That's really what's important. We can tolerate mild illness that keeps people at home, but what we really want to prevent is we want to prevent severe and critical disease. And when we just look at that subcategory of illness from a global perspective, you see at day 14, it was nearly 77% efficacious, and actually even a little bit higher at day 28, 85% efficacious. If we look at effect on preventing hospitalizations at day 14, you see that there were 2 hospitalizations among the vaccine recipients compared to 29 amongst the placebo. So that's a 93% vaccine efficacy rate at preventing hospitalization within 2 weeks. If we go beyond 2 weeks and look at greater than 4 weeks, there were no hospitalizations, 0 hospitalizations in the vaccine recipients and 16 in the placebo recipients. And this is a nice curve to demonstrate that this is when patients get vaccinated, and following them out at 2 weeks, you start to see a clear separation in the patients who were vaccinated with vaccine versus those who were who received placebo. And with time, we start to see those graphs actually separate even more. So this is what you want to see when you compare a placebo-controlled trial. You want to see early separation of the vaccine recipients versus the placebo recipients. And this is a busy slide, but I want you to concentrate just on this section showing the dots with the lines. And this is just to demonstrate that there was equivalent efficacy across all pre-specified groups that were analyzed. So if we look at age, younger versus older populations, we see these lines overlap. So we see overlapping efficacy versus age. We see patients that had comorbidities, overlapping efficacy for both patients with and without comorbidities, no significant differences with regards to sex, and good protection regardless of race and ethnicity. And now let's turn our attention to reactogenicity. So reactogenicity is just a fancy term of side effects from the vaccine. And we know that when we have side effects to a vaccine, they can be categorized as local, like pain at the injection site, or redness, or firmness and duration at the injection site. And then there's also more systemic reactogenicity, things like fatigue, muscle aches, headache, chills, fever. And we know that these are expected. They're side effects that are expected. And it honestly is a reflection of our immune response to the vaccine. And we do know that the COVID vaccines are associated with reactogenicity. So I want to walk you through some of the uh, differences among the different vaccines, because you've probably heard from media reports or from friends or family who may have been vaccinated, having had experienced some side effects that made them feel sick to the point where they could not work or they needed to stay home or limit activities for a couple of days. And we understand this and we counsel our patients about this, that this may happen. And if you get these side effects, it's absolutely fine to treat yourself with acetaminophen or Tylenol or a nonsteroidal anti-inflammatory like Motrin. And it's common, it's more common after the second vaccine versus the first vaccine. It's also more common in younger people as opposed to people over 60. And so it's something that you should be aware of. But with this vaccine, it's a one-dose vaccine, and the reactogenicity profile is certainly favorable when we compare it to the mRNA vaccines. The top panel here demonstrates the reactogenicity in the vaccine recipients. So it's looking at injection site pain, erythema, and swelling at the injection site. Grade 1 is mild. Grade 2 is moderate. Grade 3 is something that's severe enough that you would probably not want to go to work, or you would probably not want to conduct your normal activities of living, and you would probably self-medicate. So let's look first at grade 3, because those are the ones we really want to avoid. And you could see any one of these local side effects in the vaccine recipients was less than 1% among vaccine recipients with the Janssen vaccine. And it's not that dissimilar to the placebo, the saline placebo injection. So the side effects, the local side effects, are very tolerable with this particular vaccine. Now let's move on and look at the systemic reactogenicity from this vaccine. So these are things that are characterized as fatigue or feeling tired, headache, myalgias or muscle pain, nausea, or fever. And again, the top panel reflects the Janssen or J&J vaccine, and we'll concentrate on the grade 3 adverse events, because those are the ones that you really don't want to have because it makes you feel lousy. And you could see that in the younger population, 18 to 59 years of age, the rate of one of these adverse events that may have prevented you from going to work or going to the gym was 2.3% versus placebo, which is 0.6%. That is an extremely low rate if you were to compare it to the mRNA vaccines. You could see again, these side effects are lower, similar to the mRNA vaccines, as people are older in age. And because this is a one-shot vaccine, a one-and-done vaccine, so to speak, you're not having to get that second vaccine, which we know with the mRNA vaccines are associated with more of the local and systemic reactogenicity. And to put this into some better perspective for you, there are 5 vaccines listed here. The Shingrix vaccine is known to be the most reactogenic. That's the shingles shot. That is the number 1 reactogenic vaccine. So for anybody who's had that, you probably can relate. The Moderna ranks number 2 in terms of reactogenicity overall, followed by the Pfizer, number 3, and then the Janssen or J&J vaccine. And last on the list is the flu vaccine. So you could see that there's one advantage that in terms of side effects and less need for having to have some inconvenience due to 1 to 2 days of feeling lousy after the second dose of the mRNA vaccines. In this clinical trials, the investigators are required to report all sorts of adverse reactions, regardless of whether they think it's related to the vaccine or not. And some of the other reported side effects were hypersensitivity reactions like rash or like hives or urticaria. And there really was not much of a difference between the vaccine recipients and the placebo recipients. During the clinical trial, there was no cases of anaphylaxis. However, one surfaced shortly after the data cutoff for presenting to the FDA. So there has been a case of anaphylaxis that has surfaced. So it's not out of the realm of possibilities, but all the vaccine sites and vaccine clinics can manage anaphylaxis and hypersensitivity reactions that might occur. There was a little bit of a mismatch in terms of venous thrombotic events. What do I mean there? I mean things like pulmonary emboli, myocardial infarction, or cerebrovascular accident or a stroke. However, it's not clear that there's any association because when they investigated these cases a little bit more, these patients had other risk factors for these events. Similarly, with seizures, although there was a little bit of an imbalance, 3 of these 4 patients had a history of seizure disorders and epilepsy, so not likely related to vaccination. There is a little bit of a trigger here in terms of tinnitus that's ringing in your ears. There were 6 cases in the vaccine recipients, none in the placebo recipients. So this is something that the FDA will require the manufacturer to continue to monitor as the vaccine is rolled out. And in terms of these other things that I have listed here, no major areas of concern. There was only 1 case of Bell's palsy, 3 cases of Bell's palsy in the vaccine recipients versus 2 in the placebo. This is lower than with the mRNA vaccines, but clearly not above the background rate of Bell's palsy in the general population. So in conclusion, what I'd like to say is that the Advisory Committee on Immunization Practices has no preference for any 3 of the authorized COVID-19 vaccines. They're all excellent vaccines. The Janssen phase 3 trial should not be directly compared to the mRNA vaccines because the studies were done at different times in different geographic regions, while different circulating variants were present, and where there was a higher background of severe disease at the time of the Janssen clinical trial. This vaccine, like the others, provides excellent clinical efficacy against disease, particularly against severe disease and against hospitalization. 93% efficacy with the Janssen vaccine. There were 2 cases in the vaccinated group, 29 in the placebo group at day 14, and none at day 28 in the vaccine group. And there were no COVID-related deaths in the vaccine group in this clinical trial. So I'm going to stop sharing my screen and turn it over to your questions, which I look forward to.
Thank you, Dr. Bruno-Murtha. Thank you so much. That was just fascinating. I think we've all gotten a tutorial in some of the science behind vaccine development and all the factors that go into it. It's remarkable. I mean, it's also remarkable to think that we were successful in developing and testing these vaccines in 1 year. I mean, we've never done anything like that before, right?
Historic, yes.
Yeah, but yet, even though it was done so rapidly, as you've explained to us, it was done very safely and with very rigorous clinical trials, as you so carefully took us through.
Absolutely. And we have so much more safety data that CDC has shared with us through that VSafe app. It's a phone app that you get when you have an option to participate in when you get vaccinated. And they have so much data that they're not seeing any unexpected side effects emerging. And they also have a remarkable amount of data in pregnant women, and we're not seeing any safety signals among pregnant women who have been vaccinated with the mRNA vaccine. So extremely reassuring information.
Excellent. All right. Well, Tom, let's go ahead and we can take our questions from our audience. We can put the first one across the screen. All right. Wendy's question for you, Dr. Bruno-Murtha.
So the question is, which is the best vaccine for folks with severe allergies? It would depend on what your severe allergies are to. If you don't have any allergies to any of the vaccine components, I would say get the vaccine that you can get first. That would be my recommendation.
All right. And from Beth, about veterinarians being moved up in terms of the prioritization. I can try to take this one. So thanks, Beth, for the question. This has been one of the most challenging parts of the vaccine rollout, not just in Massachusetts, but all around the country, has been sort of how to prioritize when there's such a limited supply of doses. And we are expecting the number of doses, we get them from the federal government, and we are expecting that number to increase significantly in the coming weeks. But up till now, it's still been very limited. So we have been generally, following the CDC guidelines in Massachusetts. That's why we did obviously healthcare workers first and first responders. And then folks who are 75 and older, opened it up to 65 and older. But there have been some decisions made by the governor where we've moved things around, for example, teachers and childcare workers, were made eligible as of this week. So, that has been difficult and has been somewhat controversial. I've certainly heard from, a number of veterinarians in the district I represent, who share your view, and I certainly can see where you're coming from. I can tell you we've also heard from people who are grocery store workers. We've heard from people who have, severe disabilities like intellectual disabilities and autism, who are, not currently eligible. So it is very challenging. And what we have been doing is, sharing feedback that we are getting from constituents, myself and other legislators are sharing that with Governor Baker, Secretary Mary Lou Sudders, who heads up the COVID Command Center, and also with our Department of Public Health. And, they do evaluate that feedback. And as I've said, they have made some, shifts in prioritization based on that. So we will continue to, share that feedback with them.
So question, this is a very good question. Are the vaccine manufacturers going to do more experiments for permanent approval? Absolutely. They are all intending to get full approval, full FDA approval. It takes more time because for the emergency use authorization, they only had to present 2 months of safety data to the FDA for the emergency use, whereas for the full approval, it will take many more months of follow-up safety data to achieve that. I think they need 6 months total following the clinical trials. So that may happen this year.
So let me ask a follow-on question to Palani's. So what do we expect will happen? Hopefully in the next couple of months, President Biden has said even by the end of May, there'll be enough doses for every adult to get vaccinated who wants to. And again, we're hoping everybody will choose to get vaccinated. What will happen after that? Do we think we'll have to get vaccinated again, like we do for the flu vaccine annually, or maybe a booster shot 5 years from now? Does it depend on what variants of COVID get developed in the years to come, or circulate in the years to come? I know some of this is not totally known at this point, but just sharing your thoughts on this would be helpful.
Yeah, I think all those things are possibilities. We may need booster doses. We may need a booster dose with a different type of spike protein gene being expressed in it to account for variants. So stay tuned. A lot of these studies are actually happening now, looking at the need for booster dosing, tweaks. There's Moderna presented a tweaked vaccine to NIH to combat variants. So we just don't know yet. I am seeing there was a preprint just released from the University of California indicating that the mRNA vaccines look very good against the variants, even the South African variant, and that they're very good at bolstering the T cell immunity. So we're still learning an awful lot. This has only been a year, which it seems like it's a lot longer. I feel the same way, but the tremendous progress we've made in a year scientifically is really phenomenal. And we will be ready for boosters if we need them. We will be ready for tweaking vaccines if we need to. The nice thing about the current platforms, all three of the vaccines can be tweaked and manufactured in a fairly short time frame, which is really very atypical for vaccines. Usually it takes years to ramp up manufacturing. And we're going through some of those growing pains right now because we're not getting the vaccines out fast enough. It's because it still takes time, even with ramped up manufacturing. But we're getting there. And if we could all be vaccinated by May, that would be really another remarkable milestone.
Well, that's what President Biden has committed to. So we're very, very hopeful that they will deliver in getting that many doses to all the states so everyone can get vaccinated. Do we have another question, Tom? From Seth. I guess this is specifically about the J&J vaccine.
So the question pertains to whether this is gene therapy rather than a vaccine. So the gene that carries the code for our bodies to produce the spike protein is not gene therapy because it doesn't integrate into our DNA. So it's not gene therapy. It's just harnessing the power of our ribosomes to produce the spike protein so that our body can produce the antibodies and the T cell immunity that we need to prevent infection and serious disease. So it's not gene therapy per se, although a lot of the mRNA vaccines were originally studied for gene therapy, but it's not gene therapy in the context of COVID vaccines.
Great. While we're waiting for any other questions to come in, and encourage anyone who has a question for Dr. Bruno-Murtha or myself to put it in the Facebook chat, but I'm wondering about children. So remind us, I think these vaccines, all three are for, you have to be, is it 16 years old or 18 to receive it? And if that's the case, what can we expect for younger teens and obviously even younger children to get vaccinated?
Yes, so the Pfizer vaccine can be administered to 16 years of age and older. Both the Moderna and the Janssen vaccine are for adults, 18 and older. Mm-hmm. Pfizer, I think they just closed their adolescent study. They recruited for ages 12, 16, I believe. And so we should be hearing shortly in the next couple months about that clinical trial. So they may end up getting an EUA for a younger age, and they're planning to go lower. And I believe Janssen and I believe Moderna will also embark upon pediatric studies as well. I know that Janssen is also getting ready to prepare for a pregnancy study. Which will be really a welcome study. And so all the companies have an invested interest to get more information for populations, different populations, and also immunocompromised patients would be very interesting to look at that data.
For sure. As folks probably are aware, the CDC, I believe just earlier this week, came out with guidance for people who have been fully vaccinated. So they've received both of the shots of Moderna or Pfizer and have waited the additional 2 weeks, or they've received the J&J shot and 2 weeks have passed. And, in terms of what you can do in socializing with other people and whether you need to wear a mask anymore. So that's very helpful, of course. But what I'm wondering is, let's say we get to the fall and all adults, who want to be vaccinated, and again, hopefully it'll be everyone, will have been vaccinated. So we definitely have herd immunity among adults, but let's say no children have been vaccinated. What does that mean as in terms of our daily activities, and particularly in schools? Because we're hoping for a normal return to school in the fall. But what will that mean in terms of safety measures? We'll probably still have to be using in terms of distancing or masks or others, because of the fact that children will not have been vaccinated yet.
Yeah, it's a good question. I don't know anybody really knows what it exactly is going to be like in the fall. I think it's going to be a lot better than it is now. I think masks are going to be the last thing to go. I envision masks probably through the end of the year because of the point that we can't vaccinate our kids yet. Now, fortunately, kids don't get sick for the most part. Rarely do they get sick from this illness. But they're not big shedders. They're not a big source of infection, but it's possible that they can spread infection. So for that reason, they're still going to be wearing masks. And it's also to some degree, it's really going to depend on what illnesses. We could reach herd immunity, but it doesn't necessarily mean that our disease is going to be below a certain level of comfort. It should be, if the whole idea around herd immunity is that enough people are vaccinated that the disease dies down. I'm not sure with this disease it's ever going to totally die out. I think a lot of experts think it's going to be like influenza, that it's going to resurface into the fall and winter, and it's going to be a seasonal virus. So it may be that we will need to have routine vaccinations against it. But if it could just be like a common cold and not result in hospitalization and not result in death, that would be a huge victory. So I think masks are here for probably throughout the year. I think the physical distancing probably will ease up if we know that the majority of adults have been vaccinated. Um, and I think time will tell where we are, but I'm feeling confident. Things are getting better. And things are getting better, like you mentioned, Senator, in our homes among those of us who have been able to access vaccine. And it's just so heartwarming to see photos of grandparents able to hug their kids.
Sure is.
And there'll be more of that. And I would just emphasize more patience, more vigilance, and things will get better.
Sure is. I know. My parents can't wait to hug their grandchildren very soon. All right, we have a question from Tracy. This is also about the timing. So, when do you think we would be at herd immunity? Maybe you can define for our audience, for those who may not totally understand the term, what we really mean by herd immunity, and again, when you think we can get there or likely to get there.
Sure. So herd immunity is the concept that a certain percent or proportion of the population is immune to this illness. And we think it's about 80%, but that's subject to change. It depends on what happens with the variants. If the UK variant becomes the predominant strain, which it looks like it will this month in the US, I'm not sure if 80% is going to be sufficient. Time will tell. It may need to be a little bit higher, but I think we're operating right now and we're thinking it's going to be about 80%. If the South African strain were to become a problem in the US, it might need to be higher than 80%. But 80% means that if 80% of the population, and this includes kids, so we know kids aren't going to be vaccinated. So we have to do a good job vaccinating adults. If they're immune or vaccinated or have had prior COVID, then there's enough immunity to have this disease kind of peter out, because there's not enough people to get infected to continue to transmit it and continue to cause disease. So that's the concept of herd immunity. And we just don't know exactly what that percent is, and it's subject to change.
And in terms of the timing, based on the rollout, I guess we can base that on what the president is saying about the number of doses, but do you have a sense of when we might get there?
Yeah, I mean, if everybody's immunized by May, if we could, we should be at herd immunity by June.
By June.
I guess it depends on if by May he means the first vaccine or the second vaccine. So if it's the first vaccine, the second vaccine is not going to be to 3 to 4 weeks later if it's the mRNA vaccine, and then you have to wait 2 weeks. So I would say by this summer, we should be there if we have good uptake of the vaccine among everybody who's eligible.
Because the point is, you're saying you got to get to 80% counting children. And since
That's
children
right.
aren't being vaccinated, obviously you have to have an adult vaccination rate well above 90%.
Yes, right. So we need to have our adults really help because the kids can't be vaccinated yet, except for the 16 and above.
Okay. All right, Tom, I think we have one or two last questions. So from Vince Dixon, the Novobex candidate vaccine. I'm not familiar with that one.
Yeah, that's a protein-based vaccine. I envision it will go before the FDA probably in the next, I'm not exactly sure, but probably in the next 2 months or so. I think it will be another vaccine, another tool in our toolbox, so to speak. It's a different platform. It's a protein-based platform, but the preliminary evidence and efficacy looks very good.
Excellent. And I believe we have one or just two more. So I think we have time for those. From Deborah. Let's see if I'm not. Okay. I don't know if she's referring just to the Janssen vaccine or to all three, but they're all new, of course. So maybe you can answer it for the context of all three, Dr. Bruno-Murtha.
Of course, I've heard this concern expressed for all three vaccines after they became available because they're relatively new vaccines and people feel as though they've been rushed to market. And, they haven't been rushed to market because the platforms have actually been studied for a really long time. The part that's been rushed is the part where they insert the spike protein material to provide the instructions for our cells. And the fact that the production and the manufacturing started even before these manufacturers knew whether they were going to be approved for use. So there was a big financial risk, which really our federal government assumed largely that risk. So that's why these vaccines came to bear as quickly as they did, only because there was a huge risk and financial investment, not because they sacrificed on the science. There was no sacrifice on the science here. And to the question about whether it's better to wait and see more time, I would say it's not better to wait and see. I am still seeing new infections, and it breaks my heart when I see these new infections among people that were eligible to receive the vaccine. We are just learning about this long hauler syndrome, and it's real and it's devastating. And to have young people in the prime of their life not be able to work because they're so fatigued or they're so dizzy or lightheaded or develop neurologic problems or cardiac or it just is devastating right now. And this is so new, we don't know how to treat it. We're treating the symptoms, and we are seeing some improvement with time, but months beyond the initial illness. So we have to do everything we can to prevent people from getting sick from COVID-19. And it's still circulating. We're still having hospitalized patients. We still have people in our ICU on ventilators. We are not out of the woods by any stretch of the imagination. So I know there's been a lot of optimism recently and a lot of hope around reopening, but there is still disease in our communities. So please continue your vigilance and get vaccinated when you can, because you don't want this disease.
So bottom line, you're being very clear here. You've looked very closely at the safety of these vaccines and their efficacy, as you shared with us. And your very strong recommendation is to get vaccinated as soon as one becomes eligible to be vaccinated. Right.
Very strongly would encourage that.
Yeah. I think we may have one last question, Tom. Is that right? Yep. From Jennifer about Massachusetts getting its fair share of vaccines. So I can take a shot at this one. I believe we are getting our fair share. I think the formula the federal government uses is based on population for distributing vaccines to the states. So I think, maybe we can argue over whether it should be some different allocation formula, but that seems like a reasonable way to allocate vaccines. And then, as I mentioned in my previous answer, the CDC has provided guidelines for how to prioritize who should get vaccinated, but there is a fair bit of discretion that is left up to the states. So, for example, Maine has just been vaccinating based on age and not prioritizing based on occupation or specific health conditions. But Massachusetts and many other states have been doing it a bit differently. So it is a very vigorous debate that is ongoing around this and what's the best way to do it. And I'm no expert, but personally, I don't know that there's really a right or wrong answer. I think we just have to, hopefully get more doses in not just in Massachusetts, but across the country. I know the federal government is doing everything they can to accelerate the supply. And then again, as Dr. Bruno-Murtha said, as soon as you become eligible, you can now go on the pre-registration site as of Friday, and you can pre-register. So you'll be notified when your turn comes up, and then you'll be able to make your appointment. So that should be a lot smoother process than what has been happening to date. I think that was the last question. Tom, is that right? Great. I think we got through everyone's questions. Thank you, everybody, for joining us. Thanks for the terrific questions. Remember to continue to be vigilant, as Dr. Bruno-Murtha said. Stay safe. Get vaccinated as soon as you're eligible. And again, Dr. Bruno-Murtha, you're just a star. We're so grateful that you've taken time again to be with us and really help us understand what's happening with the pandemic and the vaccines. So everybody, thank you, and everybody have a good night.